Hi, Rasha Al-Lamee and Mike Gibson here with a year in review for Interventional Cardiology. Welcome, Rasha.
Hi, Mike. Thank you for having me.
Let's start off with some intravascular imaging studies that were big in 2023. The Lumion study showed really 2 years later no difference with intravascular guidance of PCI procedures, no difference in target lesion failure, maybe reduction in stent thrombosis. What were your thoughts?
Yeah, so I was really excited for the results of Illumian 4, and we were all really waiting for those results. We wanted to see whether OCT guidance would improve outcomes versus angiography alone. And unfortunately, in terms of the major and clinical endpoint, there was no difference between the two arms. It did show that the stent sizes were bigger in the OCT guided arm, and obviously there was less procedural complications in that arm, but that didn't really play out in terms of clinical outcomes over the long term. I guess the one thing to remember with all of the trials that we've seen this year is many of them have been affected by, in some sense, by the COVID pandemic. And that's very much what Ziad Ali and the authors tried to point to. The event rates that they were expecting in the trial were far lower, probably because patients were not presenting to hospital. And of course, the trial was powered to detect a certain level of events. And without those events, we saw no difference between the two groups. I
You
think for
know, I
someone
think
like yeah, sorry,
Yeah,
Mike.
I think, some people have said, well, okay, it was a quarter millimeter larger in the intravascular guidance group. That's what I do in my patients. I make the lumens a quarter millimeter bigger.
Yeah.
So I think practice has used the results to adapt in some ways.
Yeah, I think that's true. I mean, the problem with all of these intravascular imaging trials is they've almost come too late. Many of us have adapted how we do our PCI. We use bigger stents, we do post dilatation. We're always trying to aim for things to be as big as possible. And I think had they been done a decade ago, perhaps we'd see very different outcomes to what we're seeing now, because actually, even with angiography alone, many of us have adapted what we do.
Right. And let's look at ECLS shock. I mean, Holger Thiel and his group did a tough study to do in patients with STEMI and shock. No improvement in 30-day mortality with ECMO versus standard of care, but there was an increase in bleeding and vascular complications. So, where does this fit in now to practice, or does it fit into practice?
Yeah, so I mean, as you said, Mike, this is an impossible trial to do, right? Many of the trials that have gone before have had to stop early because they just couldn't recruit those patients. And Holger Thiel and his group have become fantastic, really, at being able to conduct trials in cardiogenic shock patients, which is so difficult. The tricky thing is, I think, ECMO for many of us is not available in many centres, particularly in Europe. In the UK, for example, we have ECMO centres and we have shock teams and shock networks, and we're getting better at that. But for many centres, we haven't had the availability. And I guess we've worried that not having ECMO available for our patients has meant that we've had poorer outcomes. In fact, this trial shows us that the outcomes are very similar. And maybe that's because these patients are just so sick and they have very, very high mortality rates. And your chance of actually improving mortality once you have a lactate of more than 3 or you've had CPR for a certain amount of time, as were the patients that were recruited into this trial, then you're already in a place of multi-organ failure and issues that mean that you don't really necessarily get things better. Having said that, as you said, the bleeding risk was very high in that ECMO arm, and maybe that's offset some of the benefit that we might see from the therapy.
And his group will present the danger results at ACC 2024. Took 10 years to complete to enroll 360 patients. So I think we're all anxiously awaiting to see if Impella will improve the outcomes. So stay tuned. And then finally, I think one of the big trials of the year was your trial, Orbita 2. Talk to us a little bit about how it impacts practice now.
Thanks, Mike. Well, look, it was again, I guess the Orbiter series of trials are also quite difficult trials to do, placebo-controlled trials of coronary angioplasty and stable coronary artery disease. With Orbiter 1, we tested the efficacy of angioplasty on a background of very high levels of anti-anginal therapy. This time in Orbiter 2, we took patients off their anti-anginal agents and we tested whether angioplasty would improve symptoms beyond a placebo procedure or compared to a placebo procedure. And interestingly, what we found was that angioplasty worked this time. It did improve symptoms, it improved exercise time, it improved, in fact, all of the endpoints that we tested. And I guess where it's left us now is a conversation about how we treat patients with stable coronary artery disease. And to be honest, what I believe is it's time for us to start rethinking how the guidelines look and maybe considering two pathways. A pathway that you can an option or a decision path that you can discuss with your patients. And that will be either patients would be put onto anti-anginal agents and they will have some symptom benefit, hopefully, from that, or offering an angioplasty procedure as an upfront option off anti-anginal agents for patients who are symptomatic with stable coronary artery disease. And you know, I hope that that's the model that we might start to kind of go forward with, and maybe modeling some of those AF ablation guidelines, thinking about two different pathways for patients and seeing which one suits them best.
Always good to have choices. Always good to let patients participate in those choices. So I think that's an advance. Well, Rasha, thanks for joining us. Hope you had a good holiday season.
Thank you very much, Mike. Merry Christmas to all the listeners. And yeah, I hope 2024 will bring us even more interesting trials.
Absolutely. And thanks to all of you for joining us here for a wrap up of 2023 in interventional cardiology.